I'm Dr. Gary Ansel. We're going to go ahead and get started with our noontime session. We hope you have a really good time here. I'm joined with two just superb colleagues, that Dr. Joe Griffin and Dr. Bruce Gray, who are going to help present and teach you about what we think is a revolution, and we think it's going to be something you really like. So with that, we're going to go ahead and get started. These are just, for your sake, you can find the indications, contraindications, but this is a peripheral arterial device. It's currently indicated for 3.5 to 6 millimeter vessels. These are our panelists, again, good-looking guys and really smart guys. You've got vascular medicine, vascular surgery, and interventional cardiology represented up here. So where did this idea come from? So I've got the ultimate disclosure. I developed this thing. Years ago it started. And the nice thing about that is, guess who that's made for? Me and you. Because it came from trying to fix pain points, because we did a lot of acute limb ischemia and we wanted to fix some of those things that were a pain. And I think this is, for you that are out there, when you use an aspiration-based mechanical thrombectomy that we've had forever, is this not a typical look? You take out the soft stuff, but then you get this little ball of organized stuff that you just can't take out. And what do you do then? You either stent it up against the side, you give thrombolysis, nobody likes that, or you call your vascular surgeon colleague and say, hey, you need to do a Fogarty and take this out. Those are all non-desirable things, because they don't usually let you get an on-table result except for stenting up against the side, and then you've put a prosthetic in a vessel that didn't really need to have a prosthetic device for the rest of their life. So we set out to develop a device that was certain characteristics for design. Simple, small. I wanted to not change what we did very much, so 6 or 7 French. We wanted it to be fast. We wanted to, have that 20-minute case if we could. We, like most people, follow up our patients in the office after we're done. It's amazing how oftentimes we take out a significant amount of blood, and then you see them and you go, how are you doing? And they go, I'm doing all right. And you always go, well, what does that mean? Well, I get short of breath going upstairs. I'm tired all the time. Why? Because their blood counts are low. So aspiration, and we know it increases your mortality for cardiac procedures, so it's never a good thing to take out a bunch of blood. We wanted to be able to quickly deal with all the thrombus, especially the organized or embolus that might be there. And I was a hospital administrator as well. And you all know the trials and tribulations of a capital purchase, so we didn't want that. We wanted to grab and go. Now, how do you figure that out? Well, I literally liked Fogarty's. I wasn't a surgeon, but I'd go in the OR all the time to watch how simple that was. And I thought, man, if we could just come up with something like that without a cut down, we'd get a lot of place. But what it really took was a funnel. But instead of a solid plastic funnel, you wanted something that would cut the debris, but better yet, let that debris or embolus get macerated and release the fluid. Why is that important? What are we made up 75% of? Fluid. So you can decrease the mass of debris that you have to take out. 2 baskets instead of a balloon, because they'll hold the basket, or they'll hold the clot. Now, why 2? Because 2 hands are better than 1. And we found that it dramatically increased the efficiency. We wanted to make sure you could see it under flow real easily. And now we have a better handle that really makes this quite efficient. So what do? We don't change what we do that much other than make us efficient. You put a hydrophilic wire through a thrombotic lesion, and Dr. Gray's going to talk about that's how you figure out if you should be doing this. They typically go right through, right? You then bring the little catheter that comes with the kit through, you take out your wire, and you put these 2 baskets distal to the clot. And then you just bring the clot back into the funnel, and then you just lock the whole device, and then it gets really hard. So pay attention really closely right now, because then you pull it out. And that's as easy as it can be. So with that, I'm going to introduce my colleague, Dr. Bruce Gray, he's got probably one of the largest experiences in the United States right now, and I'm going to let him give you some representation, and we'll ask some questions. Thank you very much.
Thank you, Dr. Ansel. Great to share the podium with Dr. Griffin as well, and thanks to Surmodics and just your willingness to share a few moments with us. I do have a conflict with Surmodics and with Gore. One of my first cases in which I got a chance to use the Pounce was this patient, a 44-year-old woman. Her chief complaint was that of right calf pain with walking, and it had started about a week before she made a trip to Hawaii. And then she limped around there for 2 weeks, and now she's been back for about a week and a half. She gets sent for a venous ultrasound by her primary care doctor, and at that time of the study, they noted that there was no flow in the popliteal artery, and that generated a prompt referral. She works as a mail carrier, so she's active walking around, and she only noticed the symptoms in the right leg. So an arterial duplex then followed, which showed the ankle brachial-index to be 0.5 on the right and 1.1 on the left. And she still had some trivial pulsatility on that right side. Promptly, an arteriogram was then done, and you notice that there's no clot in the renal arteries, no clot in the visceral vasculature, nor in the pelvis. But you do see a filling defect in the profunda femoral artery, the classic look of intraluminal filling defect. You know that's emboli, just looking at what you see in the profundus in the middle slide. It's not thrombosis, it's embolus with that appearance. And then the popliteal artery, you have two-segment popliteal artery occlusion, and it's hard to see the runoff typically in these patients in which they've had an acute occlusion. So we placed a 7 French crossover sheath from the left groin over into the right, delivered the clear delivery catheter, which is a 5 French catheter that you take distal to your clot. You don't have to take it distally initially in all cases, but in this particular instance, we did. We took the clear catheter distal and then delivered the baskets through that catheter beyond the clot, and then made one pass back into the funnel, clean the baskets out, make a second pass into the funnel, and then take a picture, and you see some presence of flow starting. And it wasn't until a third pass was made that the actually then reestablished flow through the popliteal artery down through the TP trunk, and you actually see the anterior tibial artery quite well. Almost notoriously, you always see clot in both baskets. And this takes about an hour to do that kind of case for your early case, and then as you get more efficient, it becomes quicker. And then an additional pass was made into the profunda. You just put your wire down the profunda, put that clear catheter down there, and then pull the clot out of the profunda back into the funnel, and then reestablish flow in that as well. It's very easy to manipulate the catheter and to put it into more than one position in a particular limb. We also took a picture of the left leg and noticed that there was a clot. The anterior tibial artery was open, but the tibioperoneal trunk was occluded. So rather than leaving that behind in a 44-year-old, elected just to stick the right groin, come around, and then make one pass and retrieve at least the posterior tibial artery back with runoff into the foot. And then this patient obviously needed to be very well anticoagulated after that, and then underwent a significant embolic workup. Cleaning the funnel sometimes can be the peskiest thing, but I'd say that's oftentimes a good thing because you're removing stuff, and so then you got to clean it out. You got to clean it out of the basket sometime, but the funnel, it can fold back on itself, and you can aspirate or just spray it with a syringe. So with that, I'll yield the podium to Dr. Griffin.
So Bruce, we're going to ask you a couple questions first. So this was primarily, or had a component of embolization there as well. Is there another device? I mean, you've been doing this for a number of years. Is there another device that you could have used? And if so, what would you have expected the results to be?
With regular mechanical aspiration, let's say with an angiojet or penumbra, I would remove some but not all, and oftentimes I'd have to join it with thrombolytic therapy to clean up the residual. And the older stuff doesn't seem to come out quite as nicely. The feel of this particular clot wasn't that real hard rubbery type of embolus. It was actually some fairly fresh feeling clot. So this wasn't the problematic embolus that's really hard and organized and real rubbery.
But do you think that this device takes out that rubbery stuff, that embolus that we can come
With
across?
subsequent cases, absolutely. You can feel it as that basket catheter transitions back into the sheath. You can feel how firm it is, and you get a real sense of what you're dealing with.
Super, thanks. We'll invite Dr. Joe Griffin. He's a vascular specialty center in Baton Rouge to talk to us about his experience in one of his cases. Joe.
All right. Good afternoon, everyone. Thank you for attending. Thanks for Surmotics and Lowe's for doing this. So this was actually the very first case we ever did. This was about roughly a year or so ago. There's always a backstory to all this stuff, and as you guys may know, we're really seeing a massive increase in arterial emboli and venous emboli since COVID. And just to let you guys know, in general, personally in our practice, we have a 400% increase in arterial percutaneous thrombectomy over the last 3 years compared to the 3 years prior to COVID. So we're really getting challenged here. I don't know how many guys are in here are vascular or what have you, but it's a real issue. It's a real threat, if you will, and we're trying to really figure out how to do this, not only the actual technical aspects, the devices, but as you guys know, a lot of staffing issues. So when someone's coming in with an acute arterial issue, basically time is of the essence, so you just need to get blood flow to that extremity as fast as possible, and sometimes trying to go to the operating room, you just don't have the staff. You're behind the open orthopedic fracture or whatever have you. So we just really wanted another option, and I think what I'm going to explain to you in this case is that we finally do have a very good option for specifically organized arterial clot. Organized arterial clot. So this was a very first case. This case started before Pounce actually got into my city. So we started this out as a 46-year-old female who's actually a nurse, borderline hypertensive, walking to her pediatric clinic where she works, and she's 385 pounds. 385 pounds. And all of a sudden, cannot make it to the front door, falls down, cannot ambulate. They thought she was basically having a heart attack or what have you. Brought her directly to the ER, and as you can see, she has a cold leg. Very straightforward situation. Contralateral limbs normal, no atrial fibrillation, no other medical issues to have an embolus. She still has foot movement, still has sensation, so we have a little time. But at this point, we're deciding that we need to at least try and get some type of blood flow. So going forward, we do the typical thing. We dripped TPA for the first 24 hours. In our practice, we don't go more than 48 hours. It's just something that we don't do. Also, the backstory on this is that she was the third patient that day that we had to do this. So we had 3 patients going at the same time, and there's 3 guys in my group. So, it's also a reality of what's going on down there. So anyhow, we drip TPA for 24 hours. We get a moderate result, not great. We definitely opened up some of the blood flow, as you could see there. Again, you have this thrombus that's sitting right at the bifurcation of the common femoral artery, really the superficial femoral artery right there. It's also further down in the tibial vessels, which is a very common scenario that we're seeing. So we do that. She comes back. We have a moderate result. At this time, the devices that we're using is an aspiration device. We're getting some decent result, but not enough. But at least we got out of a tragic scenario, right? So we're really trying not to bring her to the OR because she's basically 400 pounds. So at this point, the Pounce rep basically shows up the day before and explains this device to me, and I'm like, well, okay, we're going to do this right here, right now. All right, I didn't go to some course. We didn't do anything. We just had a very good rep that came in and explained everything to us. So we upgraded to a 7 French sheath because we had a 6 French sheath in. We do 1 pass with it. Again, so here, I'm sorry, I'm going in reverse. Sorry, guys, 1 second. So this is what we're dealing with, guys. You see that organized clot? That's what we're dealing with. We've done aspiration, we've done TPA, we've done ecos, and we just cannot get this out. And now at this point, I got either bring her to the operating room or take this stuff out. So that's what we did. We took it out with the device, as Dr. Gray showed you, the same technique that he uses. As you could see how organized this clot is. For people that are not surgeons, if you look at this clot, this is what we usually call an arterial plug, if you will. It's basically the consistency of a pencil eraser. That's the best way to explain it. You're really not going to get it out of there unless you physically just remove it, and that's what we're dealing with. We also had to go down in the perineal arteries with the same device, the same 7 French system. We were able to cannulate 2 of the 3 tibial vessels, which was the perineal and the PT artery. As you could see, we were able to remove that what I call stubborn thrombus, if you will, in the superficial femoral artery there. Profundus was fine. And I was able to get all the way down into the posterior tibial artery and get blood flow through that. So what are the conclusions from this? There are many, many challenging cases. We're definitely seeing this much more, and at the end of the day, what are you going to do to get blood flow as fast as possible to keep that limb functional? We really like this device. I was able to use it in all 3 arterial trees without having any other supplementation or any other things to do, although I think that may be off the IFU to go down into the tibial vessels. But in a scenario like this, you have to kind of just do what you need to do to get blood flow.
So Joe, we're going to ask you a few questions on that case because I think there's going to be some questions go through people's mind. I mean, when you originally were using this, because you didn't have it on the shelf, you were using other devices which you've had a vast experience with. Do you think that, or have you moved to a Pounce as a first-line therapy for your thromboembolism, or where does it fit in your treatment paradigm now?
Yeah, so just in general, clinically, you know, a patient comes into we see a patient, how are we going to reestablish blood flow as fast as possible? That's the number one thing. So if our option is to do it percutaneously, then we are going to do it. If it's infrainguinal, basically we know it's embolic disease on good ultrasound or CAT scan workup in either upper or lower extremity. We will definitely have this on the shelf as one of our first line treatments for sure, absolutely.
And do you think this is cost effective?
From a cost standpoint, yeah, I think it's very cost effective. If you're successful and you could keep someone in a cath lab, if you will, out of the OR, potentially out of the ICU, maybe even an overnight stay. In some instances, if you catch it early enough and before they've lost motor or neurological function and they're ambulating by the end of the day, you could maybe even send them home, you know, with anticoagulation minus the workup for the cause of embolus. So yeah, I think it would be cost effective in that sense.
And we all know that we've got a lot of contract people in our labs and ORs these days. How has his staff found it to work with the Pounce and learning experience, those kind of things?
We're blessed to be where we are. We have hybrid operating rooms, we have traditional operating rooms, we have cath labs, we have outpatient things, et cetera. A lot of our staff are very educated, and no matter which hospital system you go to. So from an intuitive standpoint, I guess the best thing to say is that the case I presented, it was never in our city, and the rep literally showed up a few hours before, and we did it, and it went actually really well, So, yeah. You go.
So Dr. Michael Backrack at Sioux Falls couldn't join us today, so I'm going to be presenting his cases. So this is a 70-year-old male with a chronic history of left lower extremity claudication. He was actually found to have complex aortic iliac occlusive disease. His initial intervention, which was stent grafting to the iliac vessels, was complicated by periprocedural thrombus formation and fragmentation of the embolus to the left common femoral artery and profunda. This is the initial angiogram. As you can see, that there was both bilateral high-grade right common carotid artery disease as well as a total occlusion at the aortic bifurcation. And then after stent grafting, which was done in a retrograde fashion, both sides, you can see that the flow is not going to the left common femoral because of that. This is what was seen down distally. There's now, you can't see this because we didn't have all the angiograms ahead of time, but the SFA was diffusely diseased, but now we have an embolus in the profunda femoral as well. He did 2 pulls. This is the kind of debris that was pulled out, just a representation of it, bright red clot. And you can see that, you know, the teaching points or embolization is always a risk with endovascular procedures, especially with dealing with total occlusions. The techniques to treat these complications, as you know, can include thrombolysis, aspiration techniques, mechanical thrombectomy, stent entrapment, and surgical embolectomy. In this case, we used the Pounce. I don't know why the last angiogram didn't show up. Whoop, let me go back. There we go. Sorry about that. And this is the profunda that's opened up, and the actual common femoral opened up as well. All right, the next is a pretty interesting presentation because I haven't seen this with other devices. We've always sent these to the OR as a cardiologist. This is an 84-year-old female with a history of chronic AFib. Anticoagulation was stopped for a dental procedure. She developed sudden onset of a cold, painful right upper extremity. And as you can tell, she had an embolus into the distal axillary and mid-brachial artery. They decided to use the thrombectomy to avoid any type of anesthesia for the lady and try to really decrease the amount of trauma to her body and avoid an incision in her brachial. The thrombectomy system was repaired, and one pass was made through this area, and you can see it was successfully removed and reestablished of a flow in the brachial artery. And actually these are, and you'll see this in all these cases, I kind of demand that no post-angioplasty or stent angiograms be done without showing you what the result was with the device itself, because that's not fair to you to say, oh yeah, we used it, we got a great result after we put a stent and an angioplasty balloon in. You don't really know what you're getting. None of these will show that. This is after only Pounce device. And this is the more distal. You can see there was no embolization. So the patient had a quick, easy treatment from a percutaneous groin effect and was discharged the next day. It was a single pass. That was what this was designed for, to be very simple and easy, but it avoided an operation lytic therapy in an elderly high-risk patient. I'm going to ask Bruce and Joe, do you use other aspiration or other devices in the arms to try to clean out those debris? Bruce, what do you use?
Angiojet and I've used penumbra, and part of the challenge is not inducing spasm, and it looked like you were able to do that with a limited amount of spasm, which is really good.
Super. Joe?
Yeah, I mean, in general, for this specific patient, especially at this age, most of the time we were still doing open, embolectomy, even if it was just as simple as bringing to the operating room and doing lidocaine or local anesthesia or what have you. I have used in the past all the devices, so aspiration, penumbra, quick clear, etc. Some of the issues we'll find, I don't understand why exactly versus the lower extremity, but I just find sometimes it embolizes a little bit more in the upper extremity. So patients will come back in 2 or 3 weeks with those real painful, very, very painful embolic necrotic issues at the end of their fingers, and it's a very painful long-term process. So I like this idea of what you have here. And the big thing in general, guys, with you're talking about an 81-year-old female. This is not the kind of patient that just is going to come in and go home, right? She's 81 years old with atrial fibrillation, and I just said we try to keep it as simple as possible with doing lidocaine or what have you in the operating room with a little sedation. This patient is not the one that's just going to go home the next day, right? I mean, she's in the hospital. She's 81 years old. You really want to try and keep 81-year-old people, 80-plus-year-old people out of the operating room as much as possible. So I kind of really liked this case. Really did.
Super. So when you guys look at the device, one of the things that people oftentimes look at is the baskets and see that there's pretty open interstices, and they'll go, what about embolization? Well, you got to remember, we pull this into that funnel, and when you're collapsing, as you're pointed out, that collapses and wraps around there. Those spaces are really small, so that we have not seen embolization being a big problem so far. Joe, we're going to turn to your second case.
All right, good. So guys, as I'm looking around the room, I'm about 45 or so. So, most of my patients are still older than me, but when you start to get up there and you're like, oh my goodness, man, this guy's my age, this could be me, you really start to think a little differently, right? Your narcissism kicks in. So, so this guy's a very nice guy. He's he's a welder, and he does a lot of travel welding. So a couple of years prior, one of my other partners had to remove an embolus from his left superficial femoral artery. And since then, he's been doing very well. He comes to clinic. He's on anticoagulation. He comes every 6 months. We do ABI surveillance. He calls us when he has issues and things of that such. But he came into clinic earlier than a 6-month follow because he had a rather sudden onset of basically claudication, right? New onset of claudication, normal ABI. He was right 0.9 or so, but now he's dropping down to 0.6. So, I'm thinking here, well, we'll go ahead and do it. Ultrasound was shown that there was an occlusion or thrombus right at that proximal SFA, right where he had the intervention a few years ago. Our ultrasound techs are very good to show if this is organized thrombus versus clot, but I knew this was more of an organized situation because we knew his history so well. So he's in my clinic. He cannot work. If you guys have a lot of patients like this, they need to go to work. They're very nervous about not working and providing for their family. So the good news is that it's not an arterial, acute scenario, but it's something that can become very worse if you don't figure it out pretty soon. So what we ended up doing with him, actually, is we brought him to our outpatient surgery center, again, for scheduling issues, right? So when we called the cath lab, we called the OR, it was just going to be at least a couple of hours wait, or at least in the middle of the night kind of thing, which we don't need to be doing. So what we ended up doing with him is doing percutaneous access in the contralateral limb, scheduled this Pounce device, outpatient thrombectomy. The good news with him, and we're fortunate, it was pretty quick. Only took about 15 minutes or so. It was one pass. We were able to remove all that thrombus, as you could see. You could see the issue really is I ended up ballooning after only because I knew this was a previously treated area, so that was part of the thrombotic kind of scenario. But went past 15 minutes. For time's sake, we did also get that thrombus out of the profundus femoris artery, which you could probably kind of see down here. So the good thing with this device, by the way, guys, is what I really like about it is you never burn a bridge. So if you pull clot back and it goes into a branch, so if you're pulling clot with that trumpet system at a bifurcation and you get a lot of clot, but maybe it wants to go into another branch of a different vessel, you just go back in and get it out of that next branch, so you don't really lose anything like that. So this was a very good situation. As you could see, he had a lot of organized clot here. It was one pass, got flow immediately, and the guy actually went home. I mean, it was an outpatient scenario, and he's doing fine. We still see him every 6 months. He's on anticoagulation. We follow him very closely. Actually, I switched his anticoagulation, and he's been doing great now. It's been about 6 months to 8 months now. So.
Joe, a couple questions. We're hearing more and more about OBLs and ASCs. You work in an OBL. Is this a device that should be stocked in an OBL, or what do you utilize for, the acute thrombotic disease or something, embolization that can happen during a procedure anywhere?
Yeah, that's a good question. We have an ambulatory surgery center, a little different than an office-based lab. We could operate there if we need to. So it's really just one more level that we are comfortable doing things there. So overall, yes, it's something that you can do. Since that case, our practice has been doing a few more. It could be a little tricky. You better have a good upfront plan, if that happens. We use it for bailout. If we're doing atherectomy or any other procedures and you all of a sudden have embolus that you were not expecting, we'll use it for that as well. We could get into a whole thing about reimbursement and stuff about that later, but you just have to be a little careful about when you do these things in a surgery center. But the quick answer is yes, we are doing more there.
Super, thank you very much. Bruce, we're gonna go to your second case.
All right. This is a 60-year-old man with acute onset of cold, insensate left foot. He's classified as a Rutherford 2B, and you can see on his non-invasive study he has absolutely flat waveforms in the left foot and toes. His right ankle break index is 0.95. No real obvious reason for the limb ischemia on presentation, but he does have a history of laryngeal cancer, and he's really not taking any medications. Arteriographically, the visceral segment looked really good. There was minimal amount of atherosclerosis in the aortoiliac segment. There appeared to be a filling defect in the mid-right superficial femoral artery and kind of faint visualization of the tibials on the right, but he was not having any complaints on that right side. On the left, it looks like the profunda looks pretty good, and then you got a cutoff of the superficial femoral artery at Hunter's Canal. And as you know, that's a very common place that you may have some atherosclerosis. However, when you use the right leg for reference, you're banking that most of what you're seeing in the left leg is going to be thrombus and not plaque, because atherosclerosis is typically symmetric. So just from your index of suspicion, you're still thinking clot. And then when you actually get some contrast down below that distal superficial femoral artery occlusion, you can see that not only does part of the popliteal artery light up, but also the posterior tibial artery as well. So strategy-wise, you're thinking, I've got to do something on the superficial femoral artery, and I'm not sure what to do on the tibial arteries because my initial non-invasive study shows absolutely flat waveforms downstream. So when you see all those things flat, you're thinking you're going two-level thrombectomy for the most part. In removing the SFA clot really wasn't too bad, although don't overreact once again to maybe some little residual clot that you see on the wall there. Make another pass, make another pass. Don't assume that that's underlying atherosclerosis in this location because you want to treat clot like clot and remove it, and you want to treat plaque like plaque and balloon it or stent it or do whatever else you want to do. Now this was early on in the experience in which the tibial arteries always look small when somebody has very poor perfusion. When it's really hard to document that, oh, that's a 3.5 millimeter tibial artery. And how do you know how big they are if you can't really fill them very well? Well, one technique is put your catheter down the tibial artery itself. Put that clear catheter down there. Just put a little contrast in there. You can see whether or not there's filling defects in there. And you make a diagnosis right at that arterial level and not from injecting contrast more proximally. And it's really helpful whether you do it at the beginning of the procedure or in the middle as you're trying to figure out what else do I need to remove to reestablish flow. In this particular scenario, a lytic catheter is placed to clean up the tibial vessels better. So we didn't burn the bridge of lysis, we just made it better. You know the key to lysis, it's a 4-letter word, begins with an F and it says flow. The more flow that you have, the better lysis you're going to get. If you don't reestablish flow, you're not going to get lysis, because when we give TPA, TPA stands for tissue plasminogen activator. Where does plasminogen come from? Circulating blood. So if I can reestablish circulating blood to where I'm delivering my drug, then it's going to be much more effective. And if I have no outflow, that's another problem for flow. So this mechanistically helps in improving the efficiency of thrombolysis as well, because flow is everything. So, and the amount of clot that you can remove with a device, sometimes you get a very nice result with 1, 2, or 3 passes. Sometimes it just takes more. Just make another pass. This is a non-over-the-wire catheter at this particular time, but oftentimes if the wire goes right down the vessel, I typically use a straight glide wire. If it goes straight down the vessel, you know it's clot. If the fellow takes it right down the vessel, you know it's clot. It's that simple. And then you know that you've got clot that you want to retrieve and then treat it appropriately. Treat clot like clot, treat plaque like plaque. And then you get to the point in which it's the pace of flow that you're watching on the screen. Pace of flow dictates whether or not you've reestablished a pulsal flow that's going to keep things working. This particular patient undergoes kind of an extensive workup, once again trying to figure out why are these patients presenting with this type of clot in an unusual fashion. But oftentimes, sometimes the workup is just not as revealing as you'd like. So we're then able to continue anticoagulation. You're not fully anticoagulating somebody that has an incision and has other issues for the most part, and it's very effective. I included a lot of the comments in that case that I've kind of summarized here on the review of more than the first few couple cases. What's been the overall experience? So when it comes to wire traversal, your hand tells you whether or not you're dealing with clot. Your hand will tell you whether or not you may have some clot that's retrievable. And that's true whether or not you got underlying atherosclerosis or not. Another helpful thing as you're pulling the baskets back through something really hard like plaque, the markers of the catheter itself will cone in, and you'll see it. You'll know where the stenosis is by the shape of the markers on the baskets. They'll show you that on the way back, and you'll feel it as you're coming back too. Then you know, okay, I know I need to treat something else there, but I'm going to remove all the clot first. You can take a long occlusion. As you know, occlusions extend up to a major branch, so you can remove a lot of the clot and then only have to balloon or stent a much shorter segment, which would portend a better long-term prognosis if you can shorten occlusions and only mechanically treat them in a more isolated segment, at least plaque-wise. But you always want to remove as much clot as you can. We do move clot around with this catheter. It's not a big deal. Go get it. Not a big deal. And any other? Oh, let me just give a few words in regards to the learning curve of the use of the catheter. I have no qualms about thrombolysis. Matter of fact, it's the most favorite thing I've always done in my career. I've loved it. I've loved the thought of it. I love the art of kind of how I'm going to set it up. I've loved all of it. However, the patient has to go to the intensive care unit. They have to lay around with a catheter in their groin overnight. You have to schedule a second session the next day on top of a caseload that's already there, and it's just not as easy pragmatically as you would like. And so initially I would take the catheter and I would remove all the SFA popliteal clot out of there, whether they had underlying atherosclerosis or not, reestablish flow, and then I'd lyse the tibial outflow. And that just kind of made sense, and I'd clean up the little debris and maybe make my toes as good as I can. I want my runoff with the lowest resistance as possible. But as I've kind of morphed, I've kind of realized, well, I can make a tibial pass. I can make a pass down that one. I can make a pass down this one. And my overall lytic rate has dropped. I would say initially with angiojet penumbra experience would be near 80%. And I'd say it's down under 30% now of how many patients need concomitant lysis. So once again, this catheter doesn't burn that bridge, and they may work in concert well together depending on what you're faced with and what you're dealing with. And I don't think it adds any significant risk going from a 6 to a 7 French sheath by using the device. One additional point is the basket wire, the wire itself that holds the baskets, that wire, it's very robust. It is extremely robust support wire. So if you ever need to replace your sheath, pull your sheath out and put a new sheath on, or put a bigger sheath in or whatever, it has all the support you need to take it from a contralateral groin into the opposite leg over the bifurcation. It's got tremendous support. So that's never an issue in regards to support in my mind. It's a really sturdy feel, but it's not overly done. And then one final point is that the radial force of the baskets are not so much that it's ripping the inner lining off the artery, which is crucial, because once you rip up down to the internal elastic lamina, that's what's going to beget intimal hyperplasia. And once you get intimal hyperplasia from a mechanical extraction, that wouldn't be a good thing. So we want the thing to remove clot, but not injure the underlying endothelium, which is what we're really trying to do. And I think for those reasons, I think the radial force of those baskets, I don't know how you did it. Maybe you can give us some insights, Gary, how you kind of thought through that process, but it seems to have enough, but not too much. Can you comment on that?
Yeah, that was, one of the things that we wanted to really focus in on, because if we couldn't make a safe device, why use it? We already had devices that we could send for a Fogarty or put a stent up aside and those kind of things. So we knew that we had tried the carotid distal protection devices, and that wasn't good enough. We just pulled through the clot too many times. Yeah, once in a while you could get out a little piece, but reproducibility was not good. But we didn't want to cause dissections or perforations or anything like that. And so there was a lot of trial and error to come up with just the right amount of radial force that makes it still very efficient, but you don't do harm to the patient, because these patients, you don't want to really hurt They've already got a really high mortality rate. We didn't want to have perforations or dissections that were going to lead to a lot more equipment usage and expense and all those kind of things. And again, this was designed to meet the pain points that we already had. And we didn't want to add more pain points by using a different device. So that was one of the big things about doing that. Super. So just some rapid fire other case examples that kind of show the uniqueness of this device. I mean, this is an SMA thromboembolization that occurred in a 49-year-old, and you can see that they just used the baskets to pull this out of the SMA and reestablish flow. You can see the debris that was taken off from the right. This is a really interesting case. This is an acute left axillary artery thrombosis in a patient with symptoms for about 2 weeks. A CTA that you see down at the bottom there, right there, showed thrombus before and after this stenosis, which we anticipated was a ruptured plaque. Kind of, I've only seen that twice in my career, so I'm not sure exactly why that occurred. You can see that then the device is placed into the distal subclavian artery. You certainly want to be past vertebral just to decrease your risk process. This is after one pull. You can see the debris that's in the funnel and the baskets. This is after the angioplasty, which occurred with the drug-coated balloon right here. We actually did an intravascular ultrasound, which we don't have the pictures for, but it showed a ruptured plaque, and really there was almost no thrombus left after just one pull of the device. This was an operator's first. This was a junior partner of mine at Riverside, Joe Campbell. This was his first case. He got taught how to do this during the case, and the case skin to skin was 50 minutes. And so, you know, one of the comments that he had and the staff was, "This isn't hard." I go, "I know, I made it for me." This is a patient that had 6 weeks of symptomatic proximal tibial artery thrombosis. You can see that, you know, as get this to run, you can see that after the removal, the patient has a really nice, this is actually the pre-picture over here. See, the SFA and popliteal are open, and then just the acute thrombosis of the tibioperineal trunk and the anterior tibial, and this is after the pull. This is just the device and what it looked like, and this is what was pulled out. You know, the one thing that you'll remember is don't go after perfection. Little pieces like that little haziness there, if they've got a good pulse, you know, you don't have to worry about that. That'll dissolve up on anticoagulation therapy. Thanks, Thermotics, for having this lunch session. They are the newcomer in the endovascular space, and you'll see that they've got a radial sheath for the OBLs and hospital setting. They actually have a balloon line that can actually do things from the radial, they're actually the new hot comer that's, you know, really being very aggressive in this area, but we want to thank them for their patronage to ICET as well as this lunch symposium. Thank you very much for enjoying your lunch with us.